So good evening to all of you teachers of ENT world, and especially my friends, Minis. And it's my honor and my pleasure to be here in this webinar. And I thanks Dr. Jankiram, Professor Jankiram, to giving me this opportunity. And probably this is first time in this bigger stage. And I also thanks Alembic team Alembics for the makers of cloth for this opportunity and endeavors and the support. And earlier, all three lectures were great deliberation with the highest level of scientific aspects because of this effort by Professor Jankiram. And here is the pioneers who inspired me all the way into this subspecialty, especially Professor Marchwani, Professor Mohan Reddy Shah, Professor R.N. Patil Shah. Not only these giants, but many of our ENT young colleagues who is always keep inspiring me by doing excellent job and propagating endoscopic ear surgery in different national and international forums. So all they are very good friend of mine. Maybe some name I can just name it: Dr. Mubarak Khan, Dr. Elia, Dr. Vitrivel, Dr. Richman, Dr. Gon, Dr. Kishan Kumar, Dr. Paman, Dr. Akshat, many, and they are all doing wonderful job. So today my topic is unveiling secrets of endoscopic ear surgery, and I believe the biggest secret is how to make this endoscopic ear surgery easy. Before I start my topic here is some facts and overview of endoscopic ear surgery. And endoscopic ear surgery is a dedicated subspecialty of otology with legacy of 50 years of research, innovation, and publication. So, and in recent publication by one of the pioneers, Professor Taravici, and dear friends of mine, Professor Mustafa Kapadia, provide an overview of endoscopic ear surgery, its development, principles, penetration in otology practice in 2018. And they review all PubMed published article on use of endoscopy in practice of otology over the last 50 years. Articles were categorized based on the date of publication, patterns, utilization, the endoscope. They also conducted 2 identical email survey in 2010 and 2018 of otologists on the use of endoscope and tabulated and compare results. So every slide showing tremendous growth of endoscopic ear surgery in last 3 decades. You can see that. In terms of article publication, use of endoscope in different situation of otology, educational program, and hands-on courses. So after seeing this encouraging trends, there is a need to discuss all standardization about endoscopic ear surgery. And further, Cohen and et al. Given classification of endoscopic ear surgery as shown in this slide. And I consider myself between type 2 to type 3. Means most of the cases I use endoscope, but when situation demand and in severe cases of cholesteatoma and infiltrative cholesteatoma, I add microscope for completion of the surgery. So from type 0 to type 3, it means from microscopic to endoscopic, complete endoscopic, we have these variables, and these are vision, view, maneuvering, compatibility, working hands, instrumentation, minimally invasive and cosmetic outcome, control of hidden areas and residual pathology, further innovation and futures. So here is this all depends upon the learning curve, preference, and adaptability of surgeon. So there is no fight at all between endoscope and microscope. We have to adapt. We have to do learning curve. We have to pass through the learning curve. And what is your preference is really matter. So what could be the learning curve for the endoscopic ear surgery? I always insist the dry temporal bone dissection with both microscope and endoscope is essential initially, because most of the time you will not get the fresh cadaver for endoscopic dissection of middle ear cleft. After that, simple OPD procedure, endoscopic procedure, it could be OPD diagnostic otology. I know almost every ENT surgeon is doing this. So there is no hitch in acceptance of this endoscopy as a diagnostic. Removal of packs, meningotomy, type 1 TIMBoplasty, meninoplasty. And later on, if you are almost much trained and confident at this stage, you can advance your skill towards advanced otology. So, what are the principles of endoscopic ear surgery as a whole? And we have 4 main principles, and these are planning and preparation, removal of disease, preservation of healthy tissue, and reconstruction. And if you consider any surgery, whether you are holding microscope or endoscope, planning and preparation is very important. But particularly endoscopic ear surgery, I consider this is most and paramount important. And removal of disease, preservation of tissues, and reconstruction goes hand to hand from beginning. It means if you have to remove the disease with preservation of tissue in maximum, your reconstruction will be sustainable and stable. So what are the steps of endoscopic ear surgery? And there are 5 main steps. There are canal access, choice of approach, bone removal, removal of disease, visualization of extent of disease, and reconstruction. So now we are at war, because if you are going to do a surgery by endoscope and microscope, you have to understand that could be one passage and pathway, and other is the battlefield, surgical field. So you have to prepare your passage as well as your surgical field. And in canal access, we have, we know already that there is a division in externodontic canal. Outer part is cartilaginous part, that is bearing the hairs, and inner part is the bony part, which is without hair. And outer part is the passage, inner part is almost a surgical field, you can say. So we have to prepare both this outer part and inner part. Preparation of both the part of the externodontic canal. So you have to start with the outer part. How you clean and remove the hairs is very important here, because most of the time we have seen many of surgeons doing surgery and smearing with some secretion which is already a stick with the hairs of outer externodontic canal wall, and there is always difficulty in seeing, because when you choose endoscope for doing ear surgery, you are choosing for better visualization and superior view. So you have to very careful about preparation. How we prepare is, this is chemical, you can do it manual, but I prefer chemical. Why? I prefer chemical. Why? Because we have a very irregular surface in the canal, and it is circular in shape, so it is very difficult to remove all the hairs in the outer part of the externodontic canal with a cold scissor and knife. So we do use chemical, that is betadine, and how to protect this betadine from toxicity and to getting a sensitive allergy reaction. So we tested all the sensitivity of the this chemical beat to the patient before going into the canal, and we see there is no reaction after 5 minutes. So we protect the internal part, that is the medial part of the externodontic canal, with a small cottonoid ball, because we have to do it very gently to avoid any injury. When you injure the medial part of the externodontic canal, that is the surgical field, you will have a very difficult time during surgery. So it puts a very small cottonoid ball very gently into the medial part of the canal, and then apply a bead over the external part and leave it for 5 minutes, because it all depends upon, it could be 3 minutes, it could be 5 minutes. So all depends upon the texture of the skin, the texture of the hair, where the hair is very much filled with the keratin, you have to apply with a longer time. In this case, this is a after 5 to 6 minutes, we can try to remove all this the chemicals with a very gentle way with the cotton, and you may find this is a very ideal situation to go inside without any obstruction. And if you do with a manual scissor, there is just many difficulties. You are not able to even clean properly, and there is chances of injury with this instrument, and ultimately you will land up in the problem during surgery. So I think this chemical, the bead, whatever is available in any part of the world, is very important to clean there. Without cleaning this proper cleaning of the external canal lateral part, you will not reach there very effectively with a superior vision. So now, how to prepare the surgical field? That is the medial part of the external canal. That is a bony portion. I usually prefer a local anesthesia for this all. It may be general also. The choice of anesthesia decided as per age of patient, as per the choice, and any associated systemic illness. In any given situation, preparation of surgical field is paramount. And in local anesthesia, if I have to choose, I always choose 2% Jalocan with Adrenaline 1 in 1000. 1 in 1000 means you have to add 1 ml of Adrenaline in 30 ml of already available Jalocan, and that becomes 1 in 30,000. And it is in my study, what I am going to present you, it is all type of age group above 12, varying the sex. So in all cases, we are going to apply this case. Even in children and old age, I use different concentration. But I am here to present you in a percent profile above 12 years and below 70 and 60 probably. So you have to prepare this way, and you have to give a 4-quadrant injection, and very importantly, there is a packing of external canal, medial part of the bony portion of the external canal with 1 in 1000 pure Adrenaline impregnated cotton or wire. And as you know, there is a half-life of this Adrenaline is 5 to 10 minutes. So you have to give at least 15 to 20 minutes to get a maximum effect, decongestant effect. And then only you will able to perform your surgery in better way. So this is a video of packing very gently. You just choose the canal and make your cottonoid ball in that size, avoiding injury to the medial portion of the external canal, which is having a home. So by doing this, and after 15 minutes, you will get a very good image of the very good sight of surgical field without any much bleeding. So and next is approach. How to approach endoscopic surgery. My approach is double door approach, and this is why this is very universal in any type of cases, whether you want to do underlay, overlay, whether you want to do any type of cholestoma, even stapes surgery. This double door flap will work very effectively. And how this is going to be a double door, you can see in this diagram. And the step wise, so the freshening of margin is very important, and first step, and then you take incision first anterior. Because why I am just taking anterior incision first, as you know, the anatomy of medial cleft is spread anteroposteriorly. The histology of the medial cleft is arranged differently and anteroposteriorly. One part is anteroinferior, other is posterior superior. Then ventilation pathway right from the anterior to posterior, going from a Cesian tube and ventilating the middle atic portion and some isthmus, and then going to editus and muscoid antrum. So all these are placed. Even in OT, if you consider this thing very judiciously, the monitor is placed entirely in between the patient, and we are sitting just posterior to the canal. So again in OT, the arrangement is like anteroposteriorly. So we have a forced choice to opt the pros anteroposteriorly. That's why we are having a two corridor to double door. We can say that double door approach to do this complete the surgery, and that is the anterior door and posterior door. How it met? This is anterior door. We take an incision in anterior canal wall, just 5 to 6 mm lateral to the bony annulus, and then make a wide anterior door. And then we used to take this incision. It could be 1.2 centimeter, 1.5 centimeter, up to that. All depends upon, because larger the flap, larger maybe the mechanical advantage. You can park that flap anterior and posterior, depends upon your demand. So this is large flap double door technique. So after this taking incision, we can have a opening of the posterior door, and we can widen the posterior door. The posterior door can be merged with the superior portion and inferior portion with the anterior door. So there will be 360 elevation of annulus, and we have a very good corridor to visualize all the hidden corners, and very good control of the hidden corners in that way. Just such a beautiful image of this after doing this double door technique. So even we have to approach the anterior, because we learned that there is a isthmus in the medial cleft. That isthmus is placed anteriorly, just anterior to the protympanum, and there is a isthmus between the handle of Malleus and the stapes long process of the incus, and this isthmus is very prone to get obstructed during inflammatory insult and infection. So we need to visualize these two areas, constricted areas, by two dory door. That is why this is a very novel technique. Double door technique is very important. So after doing all the corridors, and after all the doors must to be anterior and posterior and superior and inferior, we place the flap again and see the requirement of temporis fascia, whatever the graft you are interested to be. And I consider this temporis fascia as a very important graft for the endoscopic ear surgery. Even Dr. Vijendra sir has already given. He always used to harvest temporis fascia. So if and how to place the temporis fascia graft through these two doors. We just start with the posterior door and come out with anterior door, because we need to avoid the over compelling of this fascia over the cesium tube opening, and there will be post-operative obstruction of ventilation and then failure. So this is how I do the double door technique, and what are the advantages of double door techniques. Advantage of double door techniques we can enumerate one by one. Actually, we need to have two corridors to visualization of anterior and posterior compartment of the medial cleft. Second, we have a passage for graft placement, and that graft will go all around adherent to the 360 adherent to the bony canal wall, and that is the main part of the success of taking in the graft very fast in post-operative period. So in this way, we are having a very non-invasive, minimally invasive technique of the endoscopic ear surgery, because most of this medical science, surgical science is going towards the endoscopic approach. We can have a very good evidence last 10 to 15 years. So how to do this double door technique? Here is a video, because this time we are going to deliver a very basic of this endoscopic ear surgery, and advance is in later part. So this is how we do the first steps of endoscopic ear TIMBoplasty. We freshen the margin with the curve peak, and this is because of the well preparation, because without preparing your externodic canal, the passage and the surgical field, you will not able to get this kind of control over the hemostasis. So again, this is because of, and we used to recommend that you use sharp instrument and the instrument of good condition. and your cotinoid ball should be of good quality. It could be surgery. It could be of good quality because you don't want to get trouble in post-operative period where there's reaction with the cotinoid fibers. So this is again opening of this anterior door, and we can visualize we have already put the cotinoid ball in the excision tube. After pressing, we can have the posterior incision from 12 o'clock to 6 o'clock, and a very good control of hemostasis here we can see because of preparation. And after entering the meso tympana, we have to merge this inferior margin of the posterior door to the anterior margin, anterior door. And again, we have to, so here is one important things we have to discuss, how to denuate the malleus when you are doing single-hand endoscopy, because you have to preserve the hearing. You have a liability to preserve the hearing in type 1 tympoplasty, and you have to denuate the malleus. So from malleus denudation is very important. You have to go from superior to inferior, and you have to test the most stable part first, then the combo part, and in that way you will get a very good denuation with this endoscopic view. And as you know, there is a umbo and there is a fibrous layer which is very capping to the umbo. So in this way you are going to have a very good wear malleus at the end, and then you have choice to place your graft and medial to that or lateral to that. That all depends upon your preference. And for the placement of graft, this time we are just going to just placing the overlay of the handle of malleus. So many a times I got a question of whether there is a blunting, anterior blunting by this method or not. So we have to prevent the anterior blunting by making the anterior recess very carefully, and you have to replace the fibrous annulus in the bony case and enforce with a very dry piece of gel foam to make anterior recess to avoid anterior blending. With the help of this Rosen knife, you can give a skin to skin closer in the extraordic canal and avoid exposure of bone and then postoperative discharge. So in this case, we have a very total perforation and underlay placement of graft. We can see in this case, and this is very common in practice since very beginning. Underlay has established the tympoplasty in many ways. So if you achieve a very good hemostasis and your passage is clean, you can perform very good surgery in compromised position, as we have a controversy in last 10 to 15 years whether microscope is good or endoscope is good. So you can see this is how beautifully we have placed the graft and making the anterior recess and avoiding the anterior blend. Next video is a video of fish out technique in total perforation and with all endoscopic approach. And this is a rectangular graft. We have already made up some hole at the junction of anterior 1/3 and posterior 2/3, and we will go and try to fishing out the handle of malleus with that hole. And you can see if you have an idea where you have already given, yeah, it's very good, fine. So in all type of placement of graft, you have to understand one thing is very important. You have to place the graft 360 degree over the bone, and your placement will be that much. You can't afford any residual gap between your residual tympanomeatal flap, tympanic membrane, and graft placement. And you can see a very good vision, a cinematic effect of the canal and all the structures. And this is how we pull out the graft to avoid overcrowding over the scission tube. And now making the anterior recess to avoid anterior planting. At the end, we have a very good view of neo-tympanum. Even we can appreciate the cone of light at the end of surgery without giving any teeny exposure of the exotic canal bone. So this is a skin-to-skin approximation with a superior vision we can have. Now, in difficult situation, because these are all situations where the canal is very wide and straightened. In difficult situation, what are the tricks to be applied for getting this double door flap approach? So, in this case, we have very prominent spine of Henle we can see here, and the canal is almost anterior recess is deep. So we try to elevate the flap, and we are targeting a total annular incision here, excision here. So there is some so in this video we can see that anteriorly we have lifted the tympanomeatal flap with the epithelial layer of tympanic membrane, and now with the posterior door we can do the same things. So we can, this is double door technique is a very universal technique. We can apply anything you want to, overlay, interlay, underlay. So you can see here how the cadaveric situation is here. Even in live, there is no bleeding at all. And we are lifting the epithelium, leaving the fibrous layer and mucous layer. So nicely we are just doing this thing. In next slide, the next video, the continuation of that, even we have to expose the handle of Malleus and remove the epithelium over that. So you have to expose the Pusaka space first, and in this video we are not getting my cursor here. Hello? Okay.
Video is not playing.
No, my cursor is not getting. It's okay now. So this slide has already now this one is, yeah. So placing the graft after removal of the total annulus, we can place the graft underlay of the Malleus. So in next slide, it is very difficult to make the anterior recess when your annulus is not there, because annulus has its own elasticity and a strength. So in this video, I'm just giving you the idea how to make anterior recess, avoiding the anterior blunting, and without annulus. So in this case, you are just very sure that there is a skin-to-skin closure, as well as making of anterior recess is very important, and that all because of very good preparation and planning. Goes gently with all the flap, all portion of the flap, and will do the skin-to-skin closure as if at the end of operation you can appreciate each and every. And I always recommend use sharp instrument and instrument of good condition. Otherwise, you will give trauma, and ultimately you will land up with a situation where you get a pearl, the epithelial pearl in postoperative period. And this is the situation, a difficult situation where the canal is curved and your prominent spinal frenulum because of the inflammation also. So after preparing very well, we are taking anterior incision to make anterior door. And in this case, it is very difficult to approach this deep recess here. So how to approach the deep recess in endoscopic methods? So we need to have two approaches in this case. Holding of instrument is slightly, you have to change the holding of instrument. You have to hold the instrument from very far, as you can see here in this case, if you have to go more medial. And one trick is that you have to keep your tip of endoscope at the outer end of extraordic canal and create a maximum zoom in situation, so that you are going virtually, you are going very close to the operating site, but it is not actually. So this two maneuver will give you a very wide space for your instrument to work in different angulation, and you will work with versatility. So you can see here the anterior recess is very deep and canal is curved, and there is an inflammation, of course. This is a case of cholesteatoma. I was trying to create the double door. So just see. Initially, I was holding a very near, and then this is a very near situation, and you have to go far and then do your procedure. So that way you will do any canal, any curve canal, any difficult situation, and you will get to creating this flap without giving any trauma to your flap, even in inflamed situation. So you can see, and we are not using any the specialized instrument. We are using the regular instrument, regular microscopic and ENT instrument, ear instrument, which used to use in very since beginning. Just see, by doing this maneuver, we can have. So always you give a cottonoid ball impregnated with Adlin, pure Adlin, to get a hemostasis, and even to avoid the trauma of the tympanomeatal flap, because skin is very important. Where in case of any ear surgery, if you want to receive a good result, canal skin you have to preserve by any way, healthiest skin. So just see, I'm getting through the deeper anterior recess, and we have to get through to remove all the attached fibrous annulus. So here we get through. So in this situation, you have to do two tricks. One is hold the instrument, whatever instrument you are taking, very far, and keep the tip of endoscope at the opening of the extraordic canal, and create a zoom in, maximum zoom in situation. So this way we can get to different situations. So what is the myth and reality we can consider of this? So is there any fight between microscope and endoscope? That is really myth, it's not reality. Superior vision, whether it is a superior vision with microscope or endoscope, obviously it is not. Superior vision is a myth because lack of depth perception in case of endoscopy and binocular vision is very important. You need to understand this thing, and you have to get through this before taking endoscopic ear surgery in your practice. Cost effective, I don't consider that cost effective is a myth. Cost effective, you have to have very good endoscopic system because 3G camera and very good technology. You have to invest equal cost the microscope has already. Easy learning curve, not at all, because a steep learning curve, and it is, in my view, endoscopic ear surgery was a step ahead of microscopic ear surgery because you have to give maximum with the minimum resources. That's why it is very important to understand. Backdoor entry of to faculty club, I never considered because this is all pragmatic approach. So this is some few important, few different video I want to show you because this is an open case and this is cat approach, and we have to see the cholesteatoma from back with endoscope. Well, how we can see this and how it looks like. This is coming from posterior to anterior to posterior. So in this case, we can plan to remove the medial part of the axontic canal and preserve most of the bony part and make it like this. And aim is to give a sustainable reconstruction. So enforcement of this medial part of the axontic canal with a full thickness tragal cartilage, and then place a graft as you want to place, and make a type 3 and type 2 situation and boomerang, whatever you need to. So endoscope can be used in this way also to avoid the cavity problem and give interiorized situation where there is a good hearing outcome. Because without middle ear cavity with air, you can't give any good hearing outcome. So we can place this temporal fascia here. And in this case also we opted for double door. So the security of graft stability was very much high. In this case, I have seen one of the various team faculty was presenting that game is over. But in this case, my case game is not over. I was doing this case and there is a dehiscence jugular valve and I give some injury, and this is situation. So don't get panic and just pack with a glint cottonite ball, and then I advance the surgery and we can have very good view of the editors in this case with a 70-degree. And after that we managed to do type 3 TIMBoplasty with ascutoplasty. And this is a very good situation here. I learned this thing from very good otologist. And this is a boomerang TIMBoplasty. When you have not option to replace the incus as well as there is a adhesive nature of middle ear, we can do boomerang TIMBoplasty type 3 with a tragal strips of tragal cartilage. And how nasally this is going to work. Just see. Yeah, so stability is very good, no doubt. Ultimately, we are able to make this middle ear airfield cavity. Now I replace with. So this is how to control the hidden areas, and Professor Joa is going to elaborate all these things, anatomy of the middle ear cleft in detail. So we have one video with 45-degree 3M endoscope. We can able to see each and every corners of the middle ear in a very clear way. If I advance the endoscope, there is a incus, stapes, malleus, all are moving. Here is the tensor tendon. And if we advance this case with this endoscope towards middle ear, and this is 45-degree, we can able to see the editors, lateral semicircular canal, the medial portion of the attic, and the cog, as well as the protein panel in detail. So we there is a situation, and we have to visualize all the things. And if your instrumentation is good, you can do all surgery of cholesteatoma when it is within the lateral semicircular canal. Now, this is a somewhat endoscopic stapes surgery, and I used to do this case with, you can see very well the preparation is very good here. And during taking of incision, there is no excessive bleeding at all. So after elevating a flap and entering into the middle ear, a very good view of round Bindonese. And now we can able to see the long process of incus and the incolor joint. Yeah. Yes. Vestibular tendon, pyramid, and with the 90-degree peak, we are going to dislocate the inguinal joint before I check the mobility. Yeah. Out flexing the suprastructure of the stapes with the curve middle. And now we have a very good view of plate. The curate should be sharp, and you have a very good control of your hand while removing the suprastructure and posterior superior overhang. And there is a wide exposure of the fill, include the entire long process of incus would be visible, the horizontal portion of the face and could be visible, the pyramid, then only your level is a good exposure. and there could be a minimal manipulation of the chorda tympani nerve. If you are not very comfortable, you can cut sharply. Now exposure is good, and now with the perforator I can make a hole over the stapes foot plate in a graduated manner. Yes, get through. We avoid using suction at this stage because there's chances of injury of inner portion of the, and with the crocodile forceps, we are here to replace the Teflon pistol. So by this way, we do usually endoscopic step is surgery, and most of the time I find very useful. This endoscope is very useful, and we have almost more than 50 endoscopic surgery observation. With the lobule fat, just sealing the check the stability of the Teflon piston, and yeah, it's moving. And now the last step, that is crimping of the Teflon ring. Okay, perfect. So what could be approach of mine if I consider entirely the tympanomuscular surgery endoscopic approach? So in case of MRM and retraction pocket and cholesteatoma, we use exclusively type 3 endoscopic surgery classification, that is total is an atic retraction pocket and limited atic cholesteatoma lateral vascular chain. We use again endoscope solely. Atic cholesteatoma with medial vascular chain, again endoscopic ear surgery. Aticoental cholesteatoma, again endoscopic ear surgery. But it must, cholesteatoma is going beyond the lateral cervical canal. If it is infiltrative, then we add macroscope and we combine the approach, and we use endoscope to visualize the corners. If possible, we can preserve the posterior bony canal wall for the sustainable reconstruction. Otherwise, canal wall down could be the outside. In cholesteatoma with complication, always combined approach. So this is how we do the ear surgery in different situation. Now, what would be the take-home message for all the viewers and faculty? There is no, actually, the Janaki Ram sir already has given a very wonderful statement that the fool behind the tool is fool. Stay away from the slavery instead of become master. Avoid fixity. There is no, even no avoid the fixity. It could avoid in any way, whether you are comfortable, and know your ability. That is most important. Thank you very much for watching.
So, Dr. Sanjeev Kumar.
Yeah.
Yeah, you're there, I hope. Yeah. I have to make certain comments after your talk. I want to make some statements. Number one is that you have now 3,000 people watching you. 3,000
Thank you very much.
is a very huge crowd. And number one. Number two is that what I usually observe in a surgeon is not maybe the result, but the way he plays with the instrument, the finesse of the surgery. And I have viewed so many endoscopic ear surgeons. I have tried it myself. I have been such a bad endoscopic ear surgeon. But when I see your movements, you are actually playing with the instruments. I am telling you, very rare to see. You're a rare breed, believe me, of
Okay, thank you very
endoscopic
much.
ear surgery. Really, I'm thoroughly impressed by you. And my opinion on you is one of the top-notch endoscopic ear
Oh,
surgeons.
thank
And
you.
I'm
Thank
telling
you.
this openly, and I am honest. I don't want to flatter you. I'm just telling you. I am, I think, older than you, so I can definitely tell you are a fantastic endoscopic ear surgeon. There's no doubt about it. So, having said that, I saw all your surgeries very critically, very nice movements. You're turning the hockey this way, that way. You are actually playing with the, and when you operate, almost it's bloodless. So much of blood usually, but it's almost bloodless. Super demonstration. Thank you very much. It's
Thank
a
you.
real
Thank you.
pleasure to watch you operate, boss. You are, the future of
Thank
Indian.
you very much, sir. Thank you. We'll try our best.
Yeah. So I have a few questions. Before the questions, I want to put forward another important webinar which we are going to do. That is on Saturday evening at 7 p.m.
Yeah.
So this is on again year Otology, and we are three classmates. Basically, we were three or four of us. One was Vetrivel, second was Ahila Sami, third was Anthony Francis. And so I'm going to moderate a session with them on Saturday. Bookmark this date, 7 p.m. And all the three, Professor Anthony, Aguila Sami, and
Okay.
Vetrivel, are going to talk on various topics in otology. This is on Saturday. And Sunday, next Sunday, we are going to do an extensive live surgery session on endoscopic sinus surgery, as well as we'll be discussing scans and cadaver dissections and things like that. That's on Sunday, next Sunday. So that's also being done by Alembic. Okay, so having said that, I have a few questions which have been coming to me.
Yeah.
So what size of endoscope do you use? I think you've already answered 3 mm, right?
No. Actually, for the surgery, it is 4 mm. Because your purpose will be defeated if you use 4 mm, less than 4 mm. But for observe or inspection of the hidden corners, you must use 3 mm 45 degree. That is recommended.
Okay. So second question is your limitations of endoscopic ear surgery, or when you need to go. Have you converted that into a microscopic ear surgery? I mean, during the surgery, have you changed?
Yeah. We have a two protocol for the inflammatory disease of ear. That is first, if type 1, if your ear is dry, your central perforation, hearing is good, and hearing is corresponding to the size of your perforation and site of your perforation. You don't need to rely and don't need to go to the CT scan and everything. You have to rely upon the auto-endoscopic finding and planning accordingly. If your size and site of perforation not corresponding to the degree of hearing loss, it means there is some pathology. What you are saying is beyond that. So in that very situation, we can ask for CT scan, we can go for a further investigation, and in that situation, we start with the endoscopic transcanal approach and making a window, making a bone removal, making a window in posterior superior region. We can see the extent of disease, whether it is going beyond the lateral semicircular canal. Then I convert the endoscopic into the microscope. And in between, we very eager to use the endoscope whenever it requires to control the hidden area.
Very, very nicely answered. Actually, another important thing I observed is that you actually dislocate the incrostapedial joint, cut the stapedial tendon, and then do the curating.
Yeah.
First time I'm seeing a person doing this. I don't know. Are all the endoscopic surgeons doing the same thing, or you're doing something different?
No. I was just trying to have minimize trauma to the quadra tympani. That is why. Other, if you try to initially, then there will be many time manipulation of chorda tympani, and that could, whether to remove the chorda tympani, then to manipulate and play with this.
Very nice. So one more question is that, what do you advise to your juniors to get started in endoscopic ear surgery? What will be one single advice which you would give to your juniors to start? What is your
Actually, what I have seen till now, that starting with the endoscope, and when you mess up with the bleeding and your all visualization, the impaired visualization, you just fed up and leave there. So try to understand the preparation and planning first, and must have a cadaveric exposure, cadaveric dissection exposure of dry. If you are not getting a weight bone, then you do a dry bone cadaveric dissection, combined endoscope and microscope. You keep hand ready to for endoscope, and whenever you use microscope, you see that same structure with endoscope. So this is the way you can get through this endoscopic ear surgery.
Okay, so actually, I'll tell you something. This time, with the blessings of my teacher, Professor Sethi, I went to the American Academy. That was last year.
Yeah.
And in American Academy, I observed something very stunning. In fact, this happened in many of these the conferences I have gone outside, and this is a very new observation which I made. Most of the talks are given to endoscopic ear surgery now, and you saw that I see the number of audience in the hall. Maximum number of audience in endoscopic ear surgery hall. So this is going to be, I'm going to tell you, revolutionize the future. People who are saying that I will not use the endoscope, I will not use the endoscope. I think actually maybe then it's going to be difficult. So
avoid the fixity about the microscope.
I feel depressed. I tried it 2 times, 3 times. I'm not able to do it.
No, I have seen your video of endoscopic ear surgery. That was marvelous. In fact,
no.
10 years back, probably.
That was the greatest struggle I did. But the way you are playing with the instrument with such a narrow canal, anterior massive overhang, you told a trick. You just have to pull the endoscope slightly outside and do it. Fabulous, my dear friend. I'm telling you, this is really impressive. Thank you so much. And really appreciate your presence and your contribution to this panel webinar. And I'm sure that many of them would definitely think about endoscopic ear surgery after seeing your surgery. That too, that Malleus handle, the way you delineate, even microscopic surgery, when I do, there's a little fibrous layer sticking. But in every case you did, there was nothing at all. Absolutely, with one hand, you were just freaking out.
Thank
super,
you.
super boss. No words. So thank you very much for being there. So let us move on.